Welcome to a TalkTools webinar. Today's presentation is Improving Job Position and Movement with Heather Vukolich. First, we'd like to thank you for choosing TalkTools for your continuing education. Our mission is improving the quality of life for those with disabilities, and TalkTools has successfully done this year after year due to your support and the work that you do, so thank you so much for choosing TalkTools. Now, if this is your first TalkTools webinar, there are two important tabs that I'd like to point out to you, the Questions tab and the Handouts tab. In the Questions tab, you can type in any question for Heather, and we will address your questions towards the end of the webinar. And in the Handouts tab, you'll find a PDF of today's presentation that you can download and keep for your reference. Now, I would like to do a quick check just to make sure everything is functioning properly. If you could say yes or no to the following question: can you see me, hear me, and see my screen? Give everyone a few seconds to get their answers in. But most of you are saying yes. For those of you saying no, if you're having trouble, please just shoot me your questions or your issues in the Questions tab, and I'll try to help those people individually.
Not seeing you.
And what should you expect when the webinar is over? Everyone will receive an email within 1 to 3 business days. In this email is a link to today's recording. All TalkTools webinars are recorded and are available for only 30 days after the live broadcast date. So please keep that in mind. Also in this email is your certificate, any PDF files related to today's webinar, and the ASHA survey. Now, if you have an ASHA number and you would like us to report it to ASHA, it's extremely important that you fill out the survey as soon as possible. It is the only way we know you need ASHA CEUs. And of course, ASHA gives us deadlines to file for all of our courses. So if you submit your survey after the deadline, we cannot go back and report CEUs for you for this class. So super important to fill out that survey. Again, you'll get that email within 1 to 3 business days. If you have any questions or you haven't received that email, please contact us directly at continuingeducation@talktools.com. So thank you again for joining us, and please enjoy the webinar.
Okay. All right, hi everybody. Let's see, let's make sure. All right, let me get my stuff going here. My name is Heather Vukolich, and I'm really excited to be here with you today. We've got some logistics happening here. I have so many client videos for you today that I'm gonna have to toggle screens because my presentation kept locking up because of so much content. So this is gonna be a little crazy, but I'm sure you can hang in there with me. And I am so not the technical person here. So we're just gonna see how this rolls and hope for the best. Let's see here. Let's get my slideshow up for you. All right, so we're gonna toggle a bit. Okay, so I think I need to read this. And I'm trying to put my screen up here so that I can see what I'm talking about and if I'm on the screen. So my name is Heather Vukolich, and I'm a certified TalkTools instructor. My role is consultant and instructor for speech and feeding therapy tools and techniques. I'm the owner of Happy Kids Therapy in Danville, California. And financially, I have no relevant non-financial relations to disclose. So I wanted to start before I even chat away here at you or with you. I wanted to ask you, can you raise your hand and tell me if you have seen a TalkTools JAW, if you've been part of the JAW course, or if you have been part of the 2-day like oral placement, like the first course. I forget what that's called. It's been so long. I'm trying to see if I can see this on here. Lisa, where would I be seeing their hand raises?
It would be under the Attendees tab.
Okay, attendees. Let me see if I can click that.
I see a couple of raised hands.
You do? Okay, hold on. I'm trying to get this moving. How many do you see?
We've got 1, 2, 3, 4.
Okay,
4 out of,
15 right now that's on. Okay, 17. Okay, people keep joining. Okay, so I want you to be able to communicate with me during this. So maybe Lisa will tell me when you have some questions. Although we have so much content, we might cover it all. We can do questions at the end too. That's fine with me. I'm trying to make this, okay, let's just do that. All right, so let's see if I can move forward with this. Okay, so just a little bit about me, because we have so much to talk about, is I'm a speech language pathologist. I've been working for 16 years. I have been working inside the doors of the Down Syndrome Connection of the Bay Area since 2010. So it's a nonprofit for children with Down syndrome. And that is my passion. Working with children with special needs and Down syndrome has always been my passion. Started when I was a little girl. I was very much included in a special day classroom that was at my elementary school because I had so much interest. And so here I am today working with children with Down syndrome. That's mostly my patient base. But I do have children with other sensory, motor, muscle-based feeding and speech challenges. And so we can talk about a variety of clients today. But a lot of my material comes from my work, obviously. So as are you, I am still learning. I love teaching about what I see every day and what I've learned from Sarah Rosenfeld Johnson, as well as a lot of the other Talk Tools instructors who I've learned underneath, as I'm sure you have as well. I was very lucky that Sarah Rosenfeld Johnson herself got to train me for my level 3 and level 4 certifications. And so I carry a lot of her knowledge and her teaching styles. Lori Overland has done a lot of teaching for my feeding as well. And, you know, we are also learning. And the more you know, the more you realize that you don't know, right? So here I am today. Here with you. I'm also a wife and a mother of 2 toddlers, which, as you may or may not know, is completely insane. And actually coming to work is a break for me. So there's Scarlett and Savannah. They are absolute trouble, 22 months and like 3.5. So one day I'll be like, my kids are so easy, but not today. So today we're going to talk about the jaw. And I love this conversation because it is so important. It is the one area where I am always pushing. It's like, Heather, I can't do all the homework that you've given me, so what should I do? You do the jaw work. Heather, I have this client and they can't move their lips and they can't move their tongue. What should I do for them? I'm always like, have you looked at the jaw? It always comes back to the jaw. And so, as you may or may not know, this is why I'm here today, but this is what you will get from this seminar or webinar today, is how important jaw work is. And when you have to only do one thing, it always comes back to the jaw, because the jaw is really that foundation for stability in the whole mouth. And we'll talk about that. So today we're going to talk about what is typical development, what's atypical development, and what's typical resting posture and atypical resting posture and the ramifications for that. Also, I'm going to teach you a bunch of jaw work, and maybe some of you that will be repeat, but I want you to be able to ask questions. So if I'm teaching a hierarchy and you're like, yeah, Heather, got it, that's basics, you know, and you're like, that's not working for me, give me a question and I will see if I can troubleshoot it with you. I don't want you to get into like super detail, but I want you to be like, what happens if I can't get a lineup on blah, 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 you know, give me some suggestions. I'm super happy to do that with you. Also, I want to show you at the end the relationship of jaw grading, speech sound making, and what an oral placement therapy program looks like. Basically with major focus on the jaw to get the sound production we want. So you'll see, it'll be great. I always have to throw in this same slide. If you've seen any of my other ones, you've seen this before. This is Gretel, and she wants to tell you about the 6 structures that compose speech clarity in your mouth. It's the jaw, lips, tongue, cheeks, abdomen, velum, okay? And in all of my classes, I just taught this same one to a parent group last week. And I always say, who knows the most important one for speech clarity and feeding production? And everyone goes, the tongue. And then I always have to go, wait, it's the jaw. So as a throwback to one of my favorite movies, Bring It On, I had to include this slide. So think of the jaw as a pyramid of cheerleaders. Think of it as, think of the mouth as a pyramid of cheerleaders. So if you have freshman cheerleaders on the bottom, okay, and they have limited skill, limited strength and stability, then do you think even these girls that are on the top, let's say they're seniors, and they have a lot of skill, a lot of strength, do you think they're going to be able to do their jobs? They're going to be able to hold their arms up, hold their legs up, do whatever tricks they need to do? And the answer is obviously no, because this pyramid is based on stability. And if you don't have stability in the foundation, then you can't have mobility in all the other associated muscle groups. So think of the mouth like this. The jaw is on the bottom. It is your foundation for stability. Then when you have stability there, then your lips and your tongue can do their jobs. They can have the mobility they need. Now, that's not to say that they won't need some work. Sometimes we have children with tongue and lip strength and tone issues, and we have to work on stimulating and working those muscles too. But those muscles would never be able to work and do what they need to do, have the mobility they need to hit their precise targets for speech and feeding if they don't have stability to hold them in the jaw. And it's the same as in the body, right? Your child is born, they have some type of disability, they get physical therapy first in early intervention, because that is the core of the body. It's the foundation for stability. Once they start getting movement there, or once they start getting stability there, then they start working on, neck control, and then they start working on trunk control, and then they start working on arms and legs. But without working on that core first, nothing else can move. So dissociation, we've probably gone over this in other classes, but it's so important to talk about. So dissociation is, and it was on my last slide too, I think I didn't even read it, but it's the separation of movement of all of these muscle groups, and it's based on stability and strength in one or more muscle groups. So, when your jaw has its strength and stability, then your lips and your tongue and your cheeks can move and do their job. So the jaw can do its job by opening and closing during speech. The tongue can do its job, right, by hitting its like alveolar placements for TD, N, and L. It can pull back and hit its, back placement for K and G. It can do all the things it needs to do because you've got stability. And then the lips can also do their jobs. And if you watched my lip webinar, you saw all the movements that the lips can do per all those speech sounds. And, all of those are based on some nice stability here. So when you have good dissociated movement, so everything is doing its own job, then you can target grading. And that is the ability to segment movement slowly. And it's based on dissociation and stability. A great example of a baby that doesn't have grading babbling would be ba 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 ba, and and then as opposed to a child who does have grading would be like this, ba 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 ba. So the jaw now has better grading. It grades appropriately per the task, right? So like a spoon, I don't have a spoon here, but a spoon feeding task, right? A baby who's just learning would go like this. And a baby or a child who is eating, ice cream off of a spoon would just go like that. That's appropriate grading per the situation. So what we will talk about is that every speech sound has its own jaw grade that is affiliated with it, and you need to grade appropriately. And you can't do that if you don't have good stability and strength in your jaw. So what we do see is we see a lot in our clients with jaw instability is funny things that they do with their mouth. One of them is wide jaw excursion. So that can look like this. My mom went to, you know, whatever, the park. So it's like this wide movement. And sometimes kids can even open their mouth to speak larger than we even use in typical speech sounds, right? So like we don't open our mouths wider than maybe like, ah, like this, or, and so sometimes you see these kids and they're really wide. And then their speech seems more laborious, right? Because they're probably, their jaw is moving side to side. They're getting all this wide excursion. They're going back and forth between wide and then really high and fixed. And I'll show you some videos of this. But these are some funny things that we see when we see jaw instability. So fixing is something I was just talking about. And that is when your cheerleaders have those freshmen on the bottom and they're so wiggly, and then the seniors on the top, they can't do all their tricks, right? Everybody holds tight together, right? Just think of that pyramid as like everybody like in this clump, like just kind of clumped together, okay? So that's called fixing. And you see it when you talk, and you see it when a kid comes in and they're talking like this and they're not moving anything. And they're not moving anything. This is a compensatory posture, obviously. It's because there's lack of stability here, so nothing can move, okay? So if you weren't awake, maybe you're awake now because I put this Leo picture in just for you. I mean, if we're gonna look at anybody's amazing facial posture, we might as well look at his, right? Doesn't he look like he's just looking in your eyes? Anyways, I digress. So Leo is the perfect picture of closed mouth resting posture. His lips are together, his teeth are together, and his tongue is right there on his palate. We actually don't know that, but that's what typical good oral resting posture is, okay? So this facial structure, he has this beautiful facial structure. His face has grown appropriately because he has correct oral resting posture. When we're talking about correct jaw movement for speech and feeding, we're talking about an open and closed vertical plane of speaking, okay? None of us speak with our jaw moving side to side. We all speak with our jaw moving up and down. That is all. And we have to have appropriate jaw grading, right? And as I speak, you're watching me, I have appropriate jaw grading. Every speech sound I say is said with precision that I've learned over time. A lot of our clients do not have appropriate grading. Absolutely not. Because we know grading is the last thing that comes in. You have to have good dissociation before you have grading, and to have good dissociation, you have to have strength and stability. So we know that per the developmental norms between the ages of 25 to 36 months, that's when we have good internal jaw stability for grading and for speech and for rotary chewing. So when you have perfect Leonardo resting posture, you can avoid things on this list. And they are speech clarity issues, feeding issues, forward tongue placement, downward growth of the mandible, your bottom jaw, retracted growth of the maxilla, a narrow raised palate, all right, the top of your mouth, the roof of your mouth, a small nasal cavity because your palate is so high that now you have this really small cavity up here and it's harder to breathe. Enlarged adenoids and tonsils. If you have a small nasal cavity and it's hard to breathe, then you're going to open your mouth. And then when you breathe through your mouth for so long, your tonsils are going to get real big. And it's like this horrible cycle. And because your tonsils are so big, then your turbinates in your nose are going to swell up. Believe me, I do not only teach this, but my daughter has this profile. And you know that I'm kicking myself for for all of this happening right now. But that is life, and that's what happens. So sleep apnea. When your jaws do not grow the way they need to grow because you have perfect resting posture, and your jaws grow this way and they remain back, what ends up happening is your airway back here is impeded because your jaws are in it, basically. It's not able to grow large. And so then you have these sleep apnea issues, as well as the fact that you might have the swollen adenoids, swollen tonsils, inability to breathe through your nose. All of this snowballs, and then here you have the sleep apnea. And then, of course, further down the road, you're looking at orthodontic treatment, starting probably at age 4+ if you have a great airway-friendly dentist or orthodontist that helps you to expand those jaws, use an orthotropic device to pull it forward. There are lots of, this area of orthodontics is super interesting, and we have this whole area of airway orthodontics. So Dr. Brian Hockel, who's a dentist, and we have given a seminar, and it's on the Talk Tools website, about airway orthodontics, sleep apnea, and oral placement therapy. So if that is an area that you feel like you'd like to learn more about, that's on there on the website for you. Okay, so look at this adorable baby with Down syndrome. I think he's like the new Gerber baby. He's so freaking cute. But if you look at his posture, lips are apart, tongue is protruded and not on the palate, right? And teeth are not together. This is an open mouth resting posture. This is not the posture that we want to see in our kids. So here we go. Well, let me actually talk to you a little bit more before I show you some videos, okay? So let's go over some terms and then we can see them in the videos. So jaw jutting. Client walks into your office and they look like this. Their jaw is jutting in one direction when they talk. That is due to an asymmetry in strength of the jaw. One side is stronger than the other. They could jut to the stronger side or they could jut to the weaker side. You have to be the judge of that. I have a little girl right now who juts only to her right side. Her lips follow as well, as you can see. So you can jut to one side like this, to the other side like that, or you can jut to the front. A lot of kids jut to the front as well. All right, jaw sliding. This is multi-directional sliding. Looks like this. You can go front, side to side or side, okay? And you see it you see it actually in both of these videos that I'm about to show you. These two little girls have jaw sliding, okay? We talked about grading difficulties, going real big wide jaw excursion or real small. We can talk about this a little bit more. I will get into it. And then fixing. Our first video of Avery in the skeleton pink little outfit, she does some fixing when she's talking. So I want you to look for it. She does some sliding. She does some big wide jaw excursion, and she does some fixing while in a slide while talking. So I think hopefully you'll get to see some of this, and we can play it twice if you need to. All right, here's where we get tricky. Oh boy, that's all I need is my emails coming up for you to see. Here we go.
1, 2, 3.
Yay. Okay, one more time and I'm going to talk to you about it.
1, 2, 3.
Sliding to the right. That's pretty good. Wide to the right. Sliding to the right. That's wide. You know, in this video, she does a lot of sliding to the right. I think she does slide to the left as well, but she did a lot of, she did some fixing and she did a lot of wide jaw excursion. All right, here's Anna. All right, this is pretty funny.
What did you do in preschool?
I kissed a boy.
You kissed a boy?
Yeah.
Who was it? What's his name?
You see that slide? Lots of sliding.
Oh, it's not Charlotte, it's Chase.
Face.
Chase.
Face.
Is he cute?
Yeah.
Yeah. Oh my
See
God.
my pizza.
You want to see the picture?
Okay, we'll do it one more time.
What did you do in preschool?
I kissed a boy.
Slide
You kissed a
to
boy?
the left.
Who was it?
Slide to the left.
What's his name?
Slide to the right. Right, left, right.
It's not Charlotte, it's Chase.
Face.
Chase.
Face.
Is he
Slide to
cute?
the right.
Yeah.
There's a lot of sliding going on right there. And she's had a lot of intensive therapy up until that point. But, and she sounds much better than she did. But we will keep working, that's for sure. Okay, let's get back here. So when someone's walking into your office and they're having an oral placement evaluation, what are you going to be doing to make sure that you catch all of these things that we're talking about today? So you're going to be looking at not only speech sounds, you're not only going to be listening for them, right? You're going to be looking at how they're made. You're going to be looking at how wide their jaw is moving when they're making the sounds. You're going to be looking at, obviously, the placement of all the articulators. We all know how sounds are made, where the tongue goes, where the jaw goes, kind of what they look like, right? I mean, and if you're like, oh, I don't know if I know that. Well, yes, you do know that. You just have to look in the mirror and do it on yourself and be like, okay, all right, where's my jaw? It's open, kind of a big amount. My tongue is not forward, it's back in there somewhere. So, all right, when I'm looking at my kiddo, what's that look like? I'm comparing. Do they make it similarly or no? So we're looking to make sure that that placement is correct, okay? And we're looking at different levels. Can they do it just at sound level? And then when they put it in words, does it just get slurry and slushy, and do they lose precision? What does that look like? What do their word shapes look like? What do their syllable shapes look like? You know, how many syllables can they produce before it all breaks down? I get a lot of kids that come in and their parents say, oh my gosh, everyone was always telling me she was so clear when she was a baby. She says ball and daddy or dada and, you know, milk. And now she got all this language and we were so excited and we've been working so hard with our early interventionist. And now you can't understand anything she says. Well, that is because of the jaw weakness. The jaw cannot support the speech and language development. So we look at things like that. We listen to parents. What is happening in the feeding? Is your client chewing food? That does not mean putting food in their mouth and doing this. That does not mean their parents say, yeah, they totally eat everything. They're such a good eater, so you don't look at it. You have to look at it, and you have to tell them to bring in different things, like an easier food, like a crunchy dissolvable cracker, like a food they would eat for dinner. Maybe that looks like vegetables. Maybe that looks like meat. You have them to bring in a challenge food. So that can be kind of up to the parents. Usually that's like a hard vegetable or maybe a gummy bear. It just depends on what the parent thinks is a challenge food. So you're having them bring in all of these different textures, consistencies of food, so you can see how they manage them in their mouth. Are they cramming a bunch of food in and swallowing it? And a lot of parents will be like, they're such great eaters, but they're not even seeing the fact that they don't chew. And so they're not using their jaw. And so their jaw doesn't have that strength, stability, and grading practice, because when you're chewing all those different textures of foods, you're gaining good strength, stability, and grading practice. And if you don't have that, then that speech might not be coming in correctly. So you're looking at the feeding and thinking, ooh, they're not really chewing very much. You're looking at the speech and thinking, ooh, you know, everything's moving around a lot. Gosh, these two are telling me a lot of information. And then maybe I'm looking at my oral motor development, and we get this in like Lori and Robin's book, and I'm looking at it and I'm thinking, gosh, they don't have a lot of tongue lateral movement, you know? Their jaw is definitely not, you know, moving in a rotary chew. Maybe they're doing something like this. That looks like a munching. I think she said that's munching. I don't know. You know, you don't have to know a lot. You just have to have the resources, you know, and you know what looks normal to you. And so when I always teach parents, I'm always like, you do it, then they do it. Count. Put a gummy bear in your mouth. Count how many times you chew it. Oh, is it 25? Okay. Count how many times your child chews it. Oh, it's 3? Well, there you go. Your child is not chewing correctly. And then, of course, you're looking at rest posture. What does my child's mouth look like? Is it open? Is the tongue peeking forward? Is it right behind the teeth? Is it in front of the teeth? Like at the lip line? Is it all the way out? Or is their mouth closed? So what are some of these deficits that encourage some of these jaw issues that we see? Well, for me in my practice, I see low muscle tone all day long walk into my office. So low muscle tone is the tension between your muscles, and it is more relaxed. It has a harder time working against gravity, and it makes children more floppy, and it makes everything so much more wiggly. So you can feel this when you start feeling people's faces. You can feel this. You can see the differences and feel the difference in tone. You can feel someone's cheeks, like your husband, your child, and you can feel kind of how firm they feel, and then you can feel your client. And once you start working on multiple people's faces, you'll start understanding that. Differences in strength. We know that low muscle tone often associates with low strength. So for me, I'm always assuming that when I see someone walk in with low tone. I'm also looking at their walking, their motor skills, all those things. If a child is 3 or 4 and not walking, I'm thinking, they probably have a lot of strength issues in their mouth. Differences in sensation. A lot of times we have low sensation in the mouth. And we see that, we know that sensory and motor are linked. So think about having a mouth full of Novocaine. When you go to the dentist, you get Novocaine, you would never eat after, right? And you think you sound funny when you speak, but you've been speaking for so long that you don't. But you would never take a drink of coffee or eat some apple or whatever after, because you might bite your lip, bite your cheek, you might choke on your food, dribble your coffee all over yourself. So when you don't feel, your motor system doesn't work well. So think about these kids. They have low muscle tone, low strength. A lot of times they can't feel as much. So they won't be able to do the things that you want them to do by saying, look at me, do this. because they really can't feel it to activate those muscles. So we see that a lot. We also see things like paralysis and paresis. So like I have a child with Mobius syndrome. He has paresis unilaterally. He's got tongue involvement as well. And he has normal muscle strength and tone and feeling on the other side. So we start seeing things like this that can interrupt our development. We see tongue tie, right? Tethered oral tissue. Sometimes when your tongue is tied, what ends up happening is your mouth hangs open and you start having low muscle tone and strength in the cheeks. You don't get a lot of good chewing going because the tongue can't move and clear the bolus. So we have feeding issues. And when you don't work out those muscles, then they don't get stronger. And then we have speech issues. So you see how these all pull together. And then we're looking at rest posture, and we've talked about that. So I think these were really interesting. When I was researching things to put in this webinar, I found this old seminar that Sarah Rosenfeld Johnson did, and I thought this really was a good resource. Okay, so you have to hang with me for 1 second, okay? These look harder than they seem, okay? So postures for function. So what she's talking about here, she's gonna show us basically 3 jaw postures that you see and what happens in the function because of them, okay? So the jaw has 8 grades, okay? So the biggest grade is this, and we don't even speak in that grade. It's not even a speech grade. That's number 8, when your mouth is really open wide, okay? Number 7, 6, 5, 4, 3, 2, 1. 1 is closed, okay? So 1 is closed, 8 is super open, and 4 and 5 are in the middle, okay? So somebody who is speaking with a high fixed jaw is somebody that's in this position, real high, okay? And they're fixed. Remember, that's a compensatory positioning where they're holding tight and not speaking very clearly and not moving their mouth very much, okay? So this person, I wish I had a video for this. I'm so sorry I don't. I just looked and looked, but it's so funny because kids with Down syndrome have this position, but I don't know, I failed, sorry. People with this high fixed jaw position often have low muscle tone, okay? Their speech a lot of times sounds lateral, mumbled, slurred, and rapid, okay? They come in, they're talking so fast and you can't understand them because nothing's really moving, okay? So I'm here to tell you that a lot of children with Down syndrome have this high fixed positioning because they don't have that dissociated movement that's based on strength. So they can't move up and down when they're trying to talk. And you get all these speech characteristics. So I kind of like having this like tied up in a bow, because if I'm like, oh, I have to evaluate a child with Down syndrome coming in, I don't really know what to expect. Oh, I have this slide that Heather said a lot of kids, could look like. So, oh, do I see all these characteristics in speech? Oh yeah, their mouth's not moving very much. Ooh, that's exactly what they look like. I like things tied up in a bow. It makes sense to me a little bit more, and it gives me vocabulary, which I like. Okay, so this is much the opposite. It is a low jaw fixed position, and it is a person that is speaking in a like this, okay? Wide jaw position. I have a video for you on this. This person a lot of times has high muscle tone, like cerebral palsy, and their speech is slow in one syllable or fast and it's a bunch of vowels and distorted consonants, which is exactly this person right here. And let me show you. This makes total sense when you watch it. Sorry. You can see the only thing he moves is like his upper face. There's no jaw movement. There you go. Okay. Let me pull this up. So there is one more that I wanted to show you really quickly, and this is a flaccid jaw drop, okay? So far we've done high and fixed, low and open, and now we're doing the in the middle one, okay? A lot of kids with Down syndrome have this positioning too, but this little girl does not. This little girl actually has a lot of jaw weakness and a lot of tongue mobility issues because she has a tongue tie. She came in for feeding. This little girl was taking an hour to eat dinner every night, and she wouldn't eat a lot. It was so laborious for her because she didn't have any movement ability of her tongue. So because she didn't get any jaw work in. So her mouth hangs open, her tongue is tightly tied to the bottom. And we talked about this, when your mouth hangs open, then your breathing is interrupted and you start breathing through your mouth and you have all these nasal complications and it just goes down the line. So now here she is, she's in massive orthodontic treatment. She probably will have her tongue tie released and she'll have to go through all of this therapeutic intervention, all because of this. So she speaks in these middle grades, okay? She doesn't move out of these middle grades at all. So her speech, she definitely has interdental tongue placement. She actually speaks pretty well. You don't see a lot of consonant and syllable omissions at this point, but she's been working hard. And let me show you that video. Here we go.
I know. I'm looking good. But no one called you. In fact, ping, say, I'm just cool. Bam, squeeze that deep honk. You are so tall. I am the tallest.
You see her jaw sliding around too.
You are growing silly. I am the coolest. You are growing silly.
Yep. So hopefully you saw her jaw wiggling around and you saw that interdental tongue placement as well. Okay. All right, jaw work. Let's see here if I have videos right away. No. Okay. So let's talk about. Let's actually ask. Does anybody have any questions on any of that? Lisa, I don't know if you can tell if
I
anybody.
don't see any questions right now.
Okay. All right. If anybody has any questions on any of that information, please shout out and I'll probably continue talking, but Lisa, let me know, okay? All right, here we go, slideshow. Oh boy, I gotta get rid of this again. There's too many screens happening here. All right, bite tube hierarchy. Let me get rid of this too. Okay, so when we are talking about jaw work, this is my go-to, number one. We always start, whether you are a baby at 4 months or you are a teenager, because if you have jaw instability and you have chewing differences and difficulty, there's no better place than starting with the jaw hierarchy. It is made out of 4 tubes. They consecutively get harder to chew. It goes red, yellow, purple, green. Now with babies, you can start with yellow because they're smaller in diameter. So the quick and dirty of this bite tube hierarchy is that you start with one red. I like to have the video here so I can see. You start at the red. I wish I had someone to model. I tried finding a demo partner today and I just blew it. So next time, what you do is you place this on the client's molar. You ask them to bite down and open, open, open. You count as many as they can do with a intact jaw alignment, okay? If this client is biting and they are sliding to the side, to the front, to the side, it does not count, okay? You do not want to practice exercise for good, nice jaw alignment in a slid position, because then you're just reinforcing that, okay? So you're counting up to 10, how many they can do in alignment. It looks like this. 1, 2, 3, 4, 5. Slide. They did 5. So this is my right side. Right side, 5. Left side. Up on 7, I slid. Left side, 6. Okay? That's the homework you're sending home for that child that day, for that week. Mom practices that and only that. You only want to practice good movement. It's not like we do in speech sometimes when we're like, hey, they got a 60% on these articulation words or whatever. We only want to practice perfection, because then it improves over time. And we don't want them to think, oh, well, sometimes when I do this, it works. And sometimes when I go in the middle, it works, because then they don't know what good movement looks like. I always use a therapy mirror. It's in my office down the hall, but it is just like a $10 Amazon mirror, right? You know, it's like plastic and it stands up just like that. And they just put it in front of their face and they have that visual feedback. Some of our clients have such a hard time feeling what they're doing that looking is so important for them. They can make sure their jaw stays in alignment when they're biting. And then just think of it as like a brace. I think of it as like a knee brace, right? You put a knee brace on and then you're going to walk or run or whatever you're doing your exercise, right? You put that on to keep all the muscles in alignment so that they're working correctly and so that you can build strength in that good alignment. Same thing here. You want to do it in alignment so you're building strength in that good alignment for speaking and feeding, okay? So let's say your kiddo can't do a good bite on this and they go to the side and this side, they go to the side. Happens all the time, okay? You take 2, put the tips on the molars, bilateral bites. Does it have to be the back molar, Heather? Does it have to be the front molar? Just on the molars. We're not getting super specific, but it's not here and it's not here, okay? It's on the molars. And I like to talk about this kind of 45-degree angle right here, because 90-degree like this, kids are going to bite their cheeks and you'll see it. They'll go, and they'll hear about it if they bite their cheek. So here you go. It's not straight in like this. It's not here. It's kind of here, okay? So bilaterals, great place to start. Truthfully, I use bilateral and unilateral almost for every child now because I think they have different goals in mind. It's so specific to the goal. So let me get to that in 1 second. Let me finish teaching you how to do this. So if you have 2 bites in alignment on these, so it could be unilateral or bilateral, then you get the okay to move to the next color, okay? So then if you have 2 in alignment bites on these, you can move to purple and then to green. And the hierarchy says you go up to 10 bites. Now, you can do every color at the same time. And jaw work is so important, especially for our children who have low muscle tone and strength. Also for children who are still growing, because your jaw, as I've learned through my work with orthodontists and dentists, your jaw continually grows until you're in your mid-teens. And so as it grows, it becomes unstable. So you continue to do your jaw work through your child's lifetime, like their child, up till teenage years, because you want to make sure that you are facilitating that great facial and jaw growth forward. And remember, so our jaws are not stuck backwards and impeding our airway. Okay, so that's the hierarchy. The directions come when you buy this Bite Tube 4-pack. They're also in the jaw book and the oral placement book. They're everywhere, right? Make sure you read them, understand them, okay? There are so many kids that'll be like you'll put the chewy tubes in and you're like, oh, she said if they don't do it on one, then you should do bilaterals. And then I put bilaterals in and they can't chew that because it's too hard. So now what do I do? Well, now you find something easier for them to chew, okay? So you get creative. For me, I like to take 2 sets. These are easy to chew. You dip them in water or juice or something, squeeze it out, put 2 in, bite at the same time. All you want is an inline bite where the child can practice that movement, okay? Once they practice on something like this, you can also take food that's safe. You can use, what else do I use? I don't know, I'll come back to it. I've used so many crazy things like foam letters, whatever's around the kid's house. Let's say you're in early intervention, you're in their house and you're like, oh, I don't know, I don't have all these crazy tools that she has. Everyone has those foam bath letters. I take 2 of those and I bite them. So it's whatever gets you that inline bite. And then what happens is over time, let's say they bite on those for a month, guess what? You're totally gonna get on yellows or reds after they have all that practice, I promise you. You can also use veggie stick chips, those long veggie straw type of things. Those are crunchy dissolvable, and if the child's safe to eat those, you can totally chew on those. There are lots of things to start with to get onto the chewy tubes, okay? So reasons I use bilateral are tongue retraction. So if I'm going for connected speech, tongue-based stability for tongue tip elevation, I'm using bilateral. If my child is speaking and they're moving all over the place, I use bilateral because I want them to have all of this experience in this up and down movement pattern that we use for speech, okay? So if you're like, I don't know if I can write this stuff into my goals because it's a weird tool and I'm working on speech, so I don't really get that. Well, no, this works exactly for speech. If your child is saying B and you need them to say B, you can use these to get that movement alignment. B, D, B. You can use those for alignment. You also gain some strength. And remember, your end goal is that they speak clearly. So whatever method you need to get there is up to you. If you're working on chewing and tongue tip lateralization, then I'm not using bilateral because that's tongue retraction. Not for that. I might be using that too, but I'm also using these, right? Because my tongue is going to seek out whatever's in my mouth. So my tongue is going to lateralize towards the tool. So I'm going to use a lot of unilateral stuff and do a lot of feeding techniques on the side that we can talk about too. Obviously, these are jaw strengthening. They create a lot of good grading movement. They create some good motor plan for speech sound production and stability for growing jaws. Okay, so let's see here. Let's move to the next one. Okay, here's some videos of kids doing these. I'm gonna get rid of this. All right, here. Okay, this is a child whose mom is just getting this in their mouth for the first time. He's very defensive, so she has had to work this up his body and finally into his mouth. So this is the beginning stage of a chewy tube for him. Good boy, yeah.
Yeah.
Oh, 10. 2, 3. You got 3. 4, 5, 6, 7, 8, 9, 10. Good. This is October.
Yeah.
Okay. And then here's the child who you can't get the tube in their mouth.
Maybe.
Tell them.
One fish, one chew.
One chew.
You want a fish? One chew.
You got to start somewhere. Good boy. There it is. Okay, here's the perfect child. The client we all want walking into our office, who was not the perfect child as a younger person, by the way, but you know, now he's great.
1,
Bilaterals, purples.
3, 4, 5, 6, 7, 8, 9, 10. Beautiful. And green.
Okay.
You really just want him going up and down, no side to side movement.
Okay. You can teach anyone to use the tools with these children. That was a one-to-one at school that I was showing. Okay. So let's talk about bite blocks. We've been talking a lot about jaw grading for speech sound development, and this is the tool that was created for specific to that. So bite blocks, as you can see on here, were created in different grades. So the smallest one here, all the way to the largest one here. So the smallest one is for sounds like E, M, B, okay, ooh. Then you have things like your large one, okay? So what happens with these is that you do in your eval, you take one of these, you start with number 2, okay? Remember, we don't speak in jaw grade number 1. Jaw grade number 1 is closed mouth. So number 2 is open just a tad bit. You place the end of this in the mouth. You have the child sit up straight and you pull, making sure the jaw is in alignment, in the child's natural alignment, okay? And you pull until they let it go, their jaw slides, or they start doing something compensatory like this, or holding onto the table, or like this, all right? So if they show any of that, you're stopping. So you're doing the other side, and you're pulling up to 15 seconds. If you put this in your child's mouth and you go, come on, bite it. Be a puppy. That's your bone. Don't let it go. You show them first. Do it with mommy. Have them hold it. And you're pulling and you're sitting up straight and they're pulling and you're like, oh, I'm going to be so strong. I'm the puppy. This is my bone. And you're teaching it to them. You're teaching it. You put it in their mouth. They can't do it. Then you go back to just establishing bite and hold. Put it in your mouth. Sometimes I do this. Who are we kidding? A lot of times I do this. Hold their head. And it seems silly. Hold their mouth closed. Okay? Don't move. Don't move. And you don't want them to be doing this. Okay? Second they do that, you go, oh, wait a minute. Let's try again. Put it again. Okay. Ooh. Hold it. 1, 2, 3, 4, 5. It looks silly, right? It is, but it's the way to get the tool into the mouth with the correct alignment, okay? Once they get good at that, you can start pulling. Another strategy I use is I take vibration, okay? The child's unable to hold, and I pair it with the bite block, and I put it in. A lot of times, what happens is the child can feel it, or that bite response happens because of vibration, and then they're able to hold it longer. All right, so you count up to 15 seconds on each side. That's each number has 3 levels, okay? So unilateral, 15 seconds. Then you take 2 of the same, these are different, pull 15 seconds, and then 15 seconds, okay? Obviously, if you buy this tool, it will come with directions, so you will know how to use them. The goals for these are stability for speech sound production, okay? And you can also use these for placement cues. I love them for placement. So a lot of times I'll do the pulling activity, and then I'll practice E. And if they're still doing E, I'll either take 1 and put it in, and if it lines them up, I practice it like that. E, B, me, P, okay? Or I can do it like this. Me, B, P, or if that's a total bust and it doesn't work, you take 2 of the same, put them in, and you do the same thing, okay? It just depends on how your child is. It just depends on the response of your child, right? It's just the stimulus that creates the response we want. And so you just have to know what response you're looking for. And for that, you're looking for a smiley face, and you're looking for the jaw to be in alignment. So the Sensi has some jaw tips as well, and they are not, they don't have all of the bite blocks levels, but they do have some. So let's say you are without your bite blocks for the day and you want to do a little bit of stability work, you can pick up one of these and do that for the day. Now you can't do bilateral with that, and you can't do a cross, but it is a way to maybe use a vibration, or if that's the tool that's on you for the day. Or if your kid's just like, I don't want that today, which a lot of kids do because the bite blocks are the least favorite out of all of them, but they make the most impact, right? So you're like, okay, we don't have to do that, or you choose which one. That's a good option. Okay, so let me show you some videos here.
Heather, we did get a question from the last video.
Great.
Lori says, so on bilateral, you are stabilizing his jaw as well with the last client? Do you understand?
If they're talking about Will, you're talking about the last video I showed?
I believe so.
Okay, so yeah, you know what? With bilateral, with the Chewy tubes, you can absolutely help the child with your hand holds to get into the alignment you want, okay? Because all you want is for them to be in the correct movement pattern so that they can build skill within that pattern. So absolutely, when you're holding those, it's hard to do it on yourself. When you're holding that, you can hold the child's cheeks like this to keep them in alignment when you're chewing. If that doesn't answer your question, ask me again. Okay. Here's Andrew. This is a really lovely way to start a bite block between a mom and a child because it takes the pressure off of the child and makes it a dual activity. His jaw's in alignment.
Beautiful.
She's
That's
pulling.
beautiful. That's great. Other side.
She's working it up his body so that he's comfortable. Oh, he's like, I'm ready. She's not going to pull. She's looking for alignment. If he's out of alignment, look, she's not telling him, no, that's wrong, right? Because he's trying so hard. So she's just not pulling at that minute. She's just going to try it again. You'll see that's a very starting point, right? Because he's like in flexion and doing, and his neck is pulling forward like this. And so or in extension, I mean. So when his neck is pulling forward like that, it's not optimal for building skill, but you've got to get that thing in his mouth first, and you've got to get the buy-in. Here's Brandon. He has great posture. He's using the bear behind him. This is just, it's like use whatever works. He loves that bear. Put it behind his head, and he sits up straight.
What's your name? You say, Ban. Thank you. Here we go. Put it in. Good. Hold your bear back. 2, 3, 6, 7. Good. 9. Oh, okay, I'll let you see in a minute. You have to do the other side.
Both sides.
Okay, no picking your nose on camera, please. Good. Nice. Head back. 1.
See how his jaw is in alignment.
Uh-oh. Let's do that again. 5. 5's too short. You could do it.
You know your clients. You know how much
Hands
you
down.
can push them.
Good
Good.
job.
All right, and then here's our perfect client, Will. He's doing bilateral number 5. So it's pretty high up in the
Right block
hierarchy.
number 5, bilateral. Get 2 in.
Okay, but
His
open.
mom's doing it with
Open.
him.
You got it. Good. Put your head back.
This is kind of a what not to do, I have to tell you, because look at his head. It's totally forward. So he's not even using the muscles necessary for this. So
That was wonderful.
the funny thing is at the time, I think it was really great, but now looking at his posture, I'm realizing that's not great. So it's kind of nice to have videos sometimes. It's always good to see those because then you're like, oh, whoops. Okay. So there are sensory-friendly bite blocks, which were originally made for children who are adverse to the red ones. Now, the purple ones are softer, more malleable. They wear out a lot quicker. I do have a couple sets of these that I use from, and truthfully, I use them most for 2 things. One of them is children with differences in dentition alignment. So children that are going through current orthodontics have funky teeth going on. Sometimes they don't meet. Sometimes, something's higher on one side than the other. I can't get the teeth to fit together, so I can't do the bilateral pulls. So I use these because they fit within all of those funky like dental issues a lot better. So I love having these on hand. The other times that I use these are to start with kids who are scared of the red ones, because using these, what you see is a lot of times they come out and they kind of scare kids when you pull like that, and they don't like it. So especially if they're young or they're just having this response, I use purples, because even when they come out, it's just different. And these, see, they're flexible, much more bendy. So the Scentsy does have purple soft tips as well that you can use for the jaw as well. So the jaw exerciser is a very high level tool, and you have to have completed all of the bite blocks before you even start this tool, okay? Oh, I didn't bring this tool with me today. Hold on. Let me see. Okay. Boo. I'm sorry. This tool, let's talk about it. This tool is for refining jaw grading and in connected speech. If you look at this tool, there are 2 of them. There is an A and a B. So there's an easier one and a harder one. So what you do is when you have this tool, let's say it looks like this, okay? There's this block type of thing in between, okay? The first position, which is on the directions, okay, is you pull this thing all the way back so that it's really wide. You place it in the mouth, okay? And the child is asked to bite down for 1 second, bite. They're asked to hold for 1 second, hold. They're asked to open for 1 second, open, okay? So that they need control at 1 second for closing, holding, opening. The next is 2 seconds, right? 1, 2, hold it, 1, 2, open, 1, 2. Okay, this is what it looks like when a child does not have correct jaw grading. Okay, so you see funny things happen. All you want is a fluid movement, right? And so you can go up to 5 seconds. You have to go up to 5 seconds. So it looks like 1, 2, 3, 4, 5. Hold it. 1, 2, 3, 4, 5. Open. 1, 2, 3, 4, 5. If at any point it is not graded with fluidity like that, you're stopping and you're practicing at that level, okay? So then the next position will be to pull this thing like right to the middle right here, and you do it all again. So then you start with 1 second, bite, and then hold for a second, and then open for a second. And as this block comes more forward, it gets harder and harder to bite that and then to grade it, okay? And then you move to the exerciser B, sign language B, and it is just a thicker exerciser, and it's even harder. Okay, so I apologize for not having that on me right now. Okay, feeding strategies. These are really fun. All right, the pre-feeding chewing hierarchy made by Robin and Lori. They teach this in their courses. This is such a great task. This is such a great process that I love going through with kids. Okay, so the whole point behind this is that you are always working at 2 levels at one time, okay? So you're working at one level with a tool to make your child safe while you're working at a safe level with food. Now, that might have been confusing. So let's start from the beginning, okay? So let's start with chewing hierarchy level 1. Now I know this chart is like, whoa, that's like a lot of writing. What's happening here? I'm not familiar with this. Okay, just hang with me here because this is not hard to get. So let's say a little person walks into your office and they put food in their mouth and it's like, and they've got no tongue lateral movement. They're not chewing that food. And you're like, where do I start with this kiddo? Oh, let me just go to my chewing hierarchy chart. Okay, it's all laid out for me. So what I do is I don't even do food in the first few times. Okay, I take a tool. Okay, oh, where are my tools? Oh, they're in the right hand column. So let's see, yellow or red chewy tubes, Scentsy round tip, trimmed toothettes. Those are all options for tools that you can use with a child, okay? And we'll just see how the child responds to that, or what tool they have, or what tool you have on you at the time, okay? And let's just go with that. So don't get crazy and worried about it. Just grab something and let's try it. So you look at this chart with the teeth, okay? So those are the bottom teeth, and we're looking at letter B, and that's the molar. You're gonna put this chewy on in that position, and you're gonna bite, okay? You're gonna bite, and you're gonna hope that you start getting some tongue movement toward the tool. Remember, your tongue will always move towards the tool. You're gonna work on that on both sides until the child can do that, and you're seeing that movement of chewing. They can chew the tube correctly. The tongue is working to the side. It's coming over to meet the tool. You're getting some repetitive chewing movement going. Then you're going to take your food item that is safe. Okay, you know it's safe. The parent says they've eaten it before. You're going to hold it. You're going to put it back here on the molar. and you're gonna do the same thing. It's totally not rocket science. It's just like, oh, I just did the tool back there. Perfect. I'm gonna take that food. I'm gonna put it back there. I'm gonna chew it. I already gave them the skill and the motor plan. Now I'm doing it with food, okay? So their homework that week might be for the parent to hold food there and for them to chew it maybe once a day, twice a day, at every meal would be amazing, you know, for like the beginning of their meals. Then at the same time that you have introduced food on chewing hierarchy level 1, you are also working with your tool on chewing hierarchy 2, because you're starting to work on the movement pattern and the plan and the skill to move to the next feeding level while you're feeding at level 1. Does that make sense? So you're always working on 2 at the same time, 1 with food and 1 with a tool. So while they're at home practicing all of this stuff on the back molars, and it could be for a while, okay, I'm talking months, you're also sending home this therapy technique, and it looks like this, okay? Go to chewing hierarchy level 2, look at the chart, see where that X is. There's an X on the teeth that's like around where the canines would be, and it says letter D, and you go, oh, wait a minute, okay, bite at my canine, bite it B, bite here, right there. You're just adding one more place where the food enters your mouth, and you're teaching your tongue to pull it back. Remember, the child's already working on chewing in the back and swallowing, so they're already getting that down. Now the whole thing is the child puts food in here, they move it to the back, and they chew it up and they swallow it. It's just that simple when you think about it. Sometimes, for me at least, charts like this can be like super overwhelming. But when I kind of understand the whole thing and it gels in my brain, then I'm like, oh, this is awesome. This totally makes sense to me. So you're doing that on both sides, of course. Here, 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 here. And you see that tongue moving, 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 moving. Okay? Then you have mom take that veggie stick that you're working on, or whatever food you're working on, and you're biting here, here. Now it's not a really big bite, okay? This is just like enough to be dissolving food. You don't want humongous pieces floating around, because then they can go to the other side and then you've lost your whole mojo, right? You've lost that motor plan. So you just want a little bite, and then you want that tongue to go to the back, a little bite. And you want to see the child learning, when food comes in my mouth from here, I pull it to the back, and then I chew it up and swallow it. So then, while you're working on food at chewing hierarchy level 2, you're working on the tool and the motor plan and movement for chewing hierarchy level 3. Okay, and that is where the 2 X's are, canine, canine. And then what I do is I say, chew it up here. So canine, canine. What I will do is this, canine, or molar. Okay, so for me, I say, when I put food in, which I have a video for you, bite here, bring it back here, chew it up and swallow it. I'm going to show you this video because it'll make a lot of sense. Come back, videos. Okay. This is yesterday in therapy, so this was great timing. Oh,
This is chewing hierarchy number 3. So it's canine, canine, and then bring it back over here, girl. Across midline and chew over there. Good job. This is hard for her, but I think really good. It's a great level to be at. Good job, sweetie. Okay, ready? Okay. Canine, canine. Bring it back over here. You got it. And she can use the mirror in front. Oh, yep, use the mirror in front of her to help direct it, control it. Okay, now we're going to switch. We're going to chew it over here now, okay? Let's do it.
Ready?
Ready? Okay, sit up straight. You got this.
Ready?
Right here. Right here. Now get it over here. Move it over. Up. Over there. Good girl.
You
Yep.
should be using a mirror in
So
front of the
difficult,
child
but you used your brain and did it. Okay?
so that
Use
they
the
can
mirror.
see what to
Ready?
do too.
Canine. Canine. Bring it back over here. That takes so much control. I'm so proud of you. I love this stuff.
That's a great example of what that looks like on a child that's ready for it but doesn't do it yet. I was like, thank you, Avery, for coming in for a session today. Okay. So once the food now comes in from the front, the child now is able to, because children, when they eat, they don't typically put their food in the back. They typically put it in the front. So now this child who maybe started like this, okay, is now able to chew when food comes from the front. They're able to now move it all the way back and chew it up, okay? So just to solidify, chewing hierarchy level 4, you're putting food in all places of the mouth, and you are asking them to move it all the way over, to grab that food, chew it up, pull it back, and swallow it. It's kind of like the end all, pull it together. So I really love watching this hierarchy work because it takes a child from literally not chewing at all to being able to manage food at any entry point. It's really cool. So the slow feed is a great complement to this, and I use it a lot, especially when I'm working on that chewing hierarchy level 1. So the slow feed is a way to feed a child food to work on repetitive chewing, because a lot of children, they bite 1 or 2 times and they swallow, and you really want to teach them, bite here in the back, chew up everything, and don't just swallow it, chew it up and then swallow it. But it's not like just a behavioral task you're asking them to do. It's the motor plan for that tongue to come over to the bolus, hold it there on the molars, and for the jaw to do its work, and for the cheek to suck in a little bit and hold everything there. It takes those 3 things to be able to work together to do this. And so how do you get that to happen? You have to motor plan, and make sure that jaw has that strength. And also the tongue has that mobility to lateralize. So you have to figure out, you have to practice makes permanent, right? So you're taking a food and you're asking the child to shred through it. Think Bugs Bunny, right? Bite, 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 bite. You can use a veggie stick with this. You can use an apple strip. You can use a green bean. I mean, whatever your child can eat at that time. You just want them to shred through it. And you increase the texture and the height of the food as you move through the bite blocks. So this child's really little. We haven't even started the bite blocks yet. So we're using something that's small and that's safe for her mouth. Now, if you don't have a food that's safe for the child's mouth, you can take a straw like this and put some puree in it, cut it in half, put some puree and freeze it. I just like put a bunch in a plastic bag and put it in the freezer. I take it out and I create something called an ice straw, and I put it in the back and the child chews. It's a safe way to learn how to chew. I love that. You can also use something called a safety feeder. You know, you've seen those mesh ones. They've been around since forever. But I like this one. It's a silicone one called a Kids Me feeder. I have it in your slideshow later. And you can hold it in the back and chew as well. And obviously on both sides. Ooh, I have a video for that. Let me just show you. You have to appreciate this video because the mom has a new baby and she's bouncing the baby while she's taking the video. So I apologize. Mom likes.
Good girl. That was perfect. Your turn.
So you don't see this, but when she took that food and put it in her mouth, she will like chew it 1 or 2 times and then swallow it and let it dissolve and swallow. Okay, so the next slide is all about gum, which is my new favorite current obsession. I love gum chewing, and I love even more proposing it to parents because they're like, what? You want my 3-year-old to chew gum? And it's funny, or really it's at any age, it's funny. So I'm like, yeah, but we're not just gonna give them gum, we're gonna teach them how to chew gum so that it is safe and so that it's therapeutic. So it doesn't take long to get the buy-in, but there is a gum chewing hierarchy. I'm sure it is in the jaw book, but basically I'm gonna teach you how to do it today. So these are the tenets, right? So when you're starting to work with a child, you always say this. Okay, you're gonna pretend like this is our gum, okay? I'm gonna say, this is gum. I'm gonna show it to them. It is not food. We do not swallow it. It does not go in your tummy. It goes in your mouth, you chew it on your teeth, you spit it out in Heather's hand. I crumble it up and we throw it in the, and they always say, trash. And you go, it's gum. Is it food? No. Do we eat it? Does it go in our tummy? No. We spit it and they say out and we throw it in the trash. And that is like the start. And you get mom to record that when you're doing that, right? So that they can remember to do that at home or show your videos so they don't have to remember that. So then you say, okay, Heather's holding it. You've got your gloves on. I'm gonna hold it. Watch me. I'm gonna put it on your teeth. 1 bite, just one. One. Take it out. Reshape it. Good job. Other side. 1 bite. Good job. Okay. This side. 2 bites. 1, 2. Other side. 2 bites. 1, 2. You go up, 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 up. Okay. This is what will happen. Okay. 3 bites. 1, 2, and the child will go like that, and they'll try to take half the gum from you. And that's when you have to grab their head and say, oh, no, 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 spit it out. And this is serious business, right? This is therapy. This is not silly business. You don't want them to swallow this gum or choke or any of those things. So, oh, nope, spit it out right now. Spit it out, open, spitting it out. Good. You do not take the gum. It's for chewing, okay? So if they did that on 3, I would work at a level of 2 chews and I would send that home. Okay, so mom doesn't have to deal with any of that. She just has to do what is working. So chances are when she comes back, she'll be like, they can chew 10 times per side, because over time that child has learned and felt safe with doing more chews. Although for your homework, you're only writing 2 chews, right and left, okay? So once that child gets up to about 15 to 20 chews with you holding it, then you can start allowing them to do 1, 2, 3, and you start moving them up on independent bites, okay? And as soon as they do something that looks funky, like they move the gum to the other side, they're doing some funny swallowing movement, the gum gets lost, it's spread out too much and they're not controlling it, they start doing this because they just have lost that bolus, then you're like, spit it out, okay? You do the other side and you work at the level at which they chewed the gum correctly. I think it's important to note that if your child ever swallows gum, it is not the end of the world and you do not want to make a big deal out of it, because many of our kids then can become adverse to it. And this is such a good way to create this nice bolus control for feeding, I use this for that. I use it for creating that bolus and control of that tongue tip lateral movement over here. I also use it as tongue tip lateral movement for as a precursor to elevation for speech sounds like TD, N, and L. Big time. That is part of my goals for that. So you're going to be okay if you swallow your gum, although you're always working at a safe level. I also use this for children who grind their teeth all day at school, chew on their hands, chew on their shirts, chew on stuff at school that they don't want to be chewed, or they're making those noises in the back of their throat or mouth all day long and they're distracting, or they need some type of centering at school. So obviously you have to go through the whole hierarchy so the child is safe to chew gum, and so that it's safe to bring to school, but it can be such a great thing to write into an IEP. So the point of chewing gum is that it is controlled and that is only on one side at a time. So this child can start chewing 15 chews, 30 chews. I think once you get past that, you start looking at the clock, you don't count anymore, and you're like, wow, you just did that for 30 seconds. So you write down 30 seconds each side. Or wow, you just did that side for 2 minutes until you kind of lost control. All right, 2 minutes each side. Now, of course, you're looking at each side. One side could be worse than the other, and you do that side twice the amount of times, okay? And that goes for any activity that you're talking about. Let me know if I left off something, but the end goal is 15-minute chews per side, and the gum gets bigger as you move through the jaw grading bite blocks. Just like the food gets bigger on the slow feed as you move through the jaw grading bite blocks, so does the gum. It's just more gum, and that's all part of the directions, okay? So let me know if you have questions on that. Diane Barr is a wonderful resource. If you don't already know who she is a Talk Tools therapist that has probably over 30 years experience, probably more, in feeding and speech. She has these wonderful blog posts on her website, and she has one blog that I print out and I give to clients all the time, and it is her feeding program of transitioning children from purees to solids. And these are the tools that she uses in those programs, and I've showed you a lot of those today, and that link at the bottom is where you can find that. And I just wanted to give you that because it's just written in plain English. Parents, professionals, anybody can understand it, which I love. So let's talk about speech development. We talked about this earlier, but I love this chart. So a child is coming in, you're doing an evaluation, and you're wondering if they're creating the speech sounds the right way. Well, when you're looking at this chart, it's able to show you the grades that the child needs to be producing these sounds in. So we talked about earlier. So look at this chart. On the top, number 1, we don't speak in that grade, okay? So that should be like grade. It should be like blacked out. So we never speak with our teeth closed, okay? A high jaw position for these sounds, M, B, P, F, V, N, S, D, all these, okay? Either you're using bite block 1 or 2. Those are the grades that you're opening to, right? 2 is this, and then 3 is this, okay? So in the medium grades are these speech sounds, these THs and then all these vowels. I'm gonna show you a vowel video in a minute. And then the low grades are k, g, and then these vowels, ah, ah. So I love this chart because it is like another one of those things where you're like, I don't really know how open the mouth should be. I own these bite blocks and I have this chart, so okay, I can kind of use these together. I know that if my child cannot use the jaw grading bite block number 2 that they're probably not going to have the grading for any of these speech sounds. Because you have to work up the bite blocks, right? 2, 3, 4, 5, 6, 7. So you can really look at this chart as you are moving up the bite blocks to know what sounds are appropriate to work on per the jaw grade you're using. So program plan development. As with any webinar, you might have seen this before. When you are working on a child who has an oral placement issue, you work on all of these areas: sensory stimulation, feeding, speech, and oral placement, all at the same time. So when we're looking at kids, I have split all these up so that you can kind of see what I would do per child, per the speech sound goal, okay? So for this kiddo, I'm working on bilabials, all right? We're not gonna get too much into the other stuff, but maybe I'm using, maybe I'm feeding them purees with a Sensi spoon or any type of spoon. Maybe I'm doing a slow feed technique. And maybe I'm also doing some apraxia shapes, some gum chewing, and some bilateral chewy tubes, okay? All of these things are gonna support my goal of bilabials. So let's look at Miss Ela and see what that looks like for her. Oh shoot, I forgot to show you the gum chewing video. I'm gonna show you that really quickly. And then I'll show you Ela.
You're gonna start there? Okay, go for it, girl. Let's see how great you can do. Good girl. Good. Yeah, get it over there. Okay. You have your timer with you? Yeah, your timer. Good job. How long do you think she can go for? Per side.
She's at least does 25 on each side.
Oh, here. Oh, wait,
So she
no,
switch sides.
this side first. Keep it there, okay?
Keep it
Yep.
there.
1, 2, 3. Keep it there.
Keep it.
Here. Uh-oh. Move it over. You got 12. Keep it there. You don't get to move it. Only mommy.
There's the therapy mirror. That's so great.
Get it back. Pull it back. Oh, okay. Mommy's turn.
Okay, so you can see a little bit. She obviously can independently chew gum, but it's only between like 12 and 25 chews per side. So that's what they're practicing at home. Okay, here's Ela. This is her bilabials program. This is gum. This is a long video, but I kind of like to show you what it looks like. It's not always easy to do this stuff with
Good
kids.
job, sister. Other side. Let's do 5 5s, okay?
Lizzie.
Yeah. Mommy's going to show you. Keep going. 2 more. And then you can see it, okay? 2 more. Okay, hold on here. Here. And then you can see it. I promise. You can see it. Good. Okay, this side, this side, this side. Okay, and then you can see it.
She has a hard time actually motor planning for this up and down
Good
movement.
job. Okay,
which
now
is-
wait. Now you tell me right here, and then you can see it. You say ba ba ba.
which is why speech is so hard for her. She has a
You do
hard time
ba,
motor
ba.
planning, even to
Oh.
chew those things.
You tell me, and then you can have balls. Ba. Okay, I'll give it to you. I promise. You want bubbles? Ba ba. Let's blow it. We can have other gum too. Okay, we will. Show me. Show me. Say ba ba. Tell me. Oh, tell me. Say ba ba. Buh, buh.
Mm,
You can do it. You can do it. You tell me, and then I'll give it to you. Buh, buh. Good trying. Buh, buh. Try this. I'll give it to you. I promise. I give it. Say buh, buh. Good job. Okay, here you go. And you know, that's how long it takes kids to plan sometimes. But you have to keep with it. Okay. So our next sounds that we're looking at are lip rounding. So ooh, oh, ow, and wah. I think this child's working on wah. So for him, he has apraxia as well as he has dysarthria. So he has jaw weakness. So we're working on the bite block number 2, as well as we're working on that wah movement. I'm not showing you, but we're also doing things like spoon slurping, slow feeds, and then some, probably some vibration, use of the toothette to get those lips moving. But he's already doing some good moving in this video. So what we really need to work on was the jaw stability so he could support the sentence. There you go. That's jaw grinding bite block number 2. Good job. Okay, what would you like? Keep going.
I put the piece.
Good job. 4 more times.
I put the piece.
Good.
I put the piece.
Uh-huh.
I put the piece.
1 more.
I put the piece.
Nice job. And so we're working on lip rounding. And so we're going to do a lip rounding good task job. too. Not only with the W. Good job. And 1 more. Oh, that's a little crazy. There we go. You blow. Those cheeks are not great. Long blow. Long blow. Cheeks in. Remember? That's the way we want it. Better. That we're getting a little bit of flaccid cheeks and lips right there. Good. Much better. No. I'm supporting his jaw. I'm supporting his jaw so that his cheeks and his lips can do what they need to do. And that's that dissociation is based on strength type of thing that's happening there. I hope that makes sense to you. I know I'm running through these kind of quickly, but I'm getting nervous about time. Okay. So again, high jaw position. We're still in that number 2 or 3 jaw grade. And we're working on lip retraction. So E and I. I work on these all day long with my kids. And so I'm doing facial prompting, right? We're doing that smiley sound. Doing bilateral slow feed. You know, your brain just exploded. Yes, you can do bilateral slow feeds. We're working on everything in alignment. And I'm probably doing chewy tubes and then bite blocks too. Do this one, and then you get to go, you get to have your house. Ready? Let's do well, good, good. Up, down, ready? Good job. We can do that one in a minute. Ready? Bite. Good girl. Another one. Almost. Okay. Good job. You do a few more. Here, let me have this, and then we do that one, I promise. Promise. Bite. Good, good. 2 more. Yep, we can do that. We'll do the house. 2 more. Right, oh, right in the middle. Good. 1. And last one. Last one. Good. Right in the middle. Good job. Very good. Okay. Show me. Say E. Oh, close.
Mommy,
Can you do E? Oh, that's even better. Good. Do it again. Keep it in the middle. E. Good. A little off to the side. 1 more. 1 more. And then house. Okay? 1 more. Here you go. Okay, do E. Okay, look. You ready? E.
Mummy, mummy.
Okay. Mummy, that was nice. E. You say E. Oh, that was better in the middle. Okay, thank you. Perfect.
E for Emma.
We're working so hard with her on those bite blocks and the chewy tubes in bilaterally so that we can get her to be in the middle here, symmetrical when she's saying E. That's hard. She is the child I work with that has the jut to the right. That's the one-way movement. Okay. So our next person is working on F and V. Okay, so that's a lower lip retraction sound, and I'm using a lot of strategies here, right? So I'm using my facial prompting and a mirror. I'm using a lower lip food scrape, so Cheerio lip is what we use in Talk Tools. I'm using jaw grading bite block number 3 to make sure her jaw is stable enough to work on F and V. And you have to remember that you don't work on F and V until you get to number 3. Okay, here is Missy Anna again.
Okay, ready? Good. Oh, that was silly business. Good job. Can you do this side? Good, you're very close. Can you try this for me? Say, tell me this, and then you get to watch your video, okay? Try. Good. Say, face.
Face.
Feet.
Feet.
Fine. Phone.
Phone.
Good, try to bite it a little bit. Phone.
Phone.
Food.
Food.
Good, try one more time. Food.
Food.
Uh-huh. Food.
Food.
That was a good try. Thank you.
You know what's something I didn't mention to you is that if a child cannot sit up straight and hold a bite block in their teeth, you can start them laying down on the floor. And that takes all of gravity out of it, and you can only work on the jaw. And I've had to do that with many little people that have core instability issues. That is a good strategy for sure. Oh, Anna has a Cheerio lip exercise that you can see as well.
Okay, ready? Are you ready? I'm gonna put it right there. Now, atta girl 1. Do it again.
This is how we get the
Okay.
motor plan
2.
for that F
Good
movement.
girl. Yes.
Lower lip retraction. It's called Cheerio lip.
Hold on. Wait for it. Good.
There you go.
3.
So I think you get the gist of that. All right. Next, we have lower lip protrusion. So I don't have a video on this, I apologize, but when you're thinking about these high level sounds, R, CH, SH, J, and J, you're thinking about what you need for those, right? So I might start off with some type of sensory in the mouth to get kind of that rounded, tensed lip position. I might use a spoon slurp to get that rounded position as well as that tongue retraction necessary for the side spread for those sounds. I also might use a button pull, and then I have to make sure that their jaw is stable at that number 3 level. So that's what I would do. That would be a great oral placement plan for that. Now we move to medium jaw. So remember, that's a little bit, let's open wider. So it's like a 4 or a 5 level. So we're looking at T, D, N, and L. You know, we work on these speech sounds all day long. And a lot of times we're really focused on where the tongue is, which is a huge deal. We want that tongue to the spot. But we also have to look at where the jaw is. It can't be clenched shut and it can't be too open. So we want it to be able to be stable at that mid range. And so we're using things to get the tongue moving, right? Like tongue hugs to get tongue pointing. We're using that chewing hierarchy because once we know that once the tongue has lateral movement, then it can elevate to the spot. We might be using bilateral chewy tubes and then bite block number 4. All of these together just to get to that TD, N, and L. So here are some examples. So Will is working on tongue lateralization here. Really hard for him to lateralize.
3. And sometimes what I do is I kind of touch the tongue. 2, 3 to get it moving.
Okay.
1, 2, 3. One more.
On the first one, you kind of touch it, or on all 3?
Kind of all of them. I kind of
Okay.
just poke it, and then it kind of activates. 1, 2. Okay, gotta get it over here. Move it. Move your tongue. Well, get
This
it
is
over there.
kind of like a chewing hierarchy number 2 exercise right there. I'm biting it 3 times, but that's okay. Then here's Michael.
We're gonna say la, la. Good job, bud. La,
So this is the
la.
bite block
Can you
number
smile?
4 or 5 right
La,
now.
la.
Probably a
Good
5.
job. Again. Yeah.
He has a bigger mouth, so we'll probably use a bigger bite block, truthfully.
Good. Lay. Lay.
This is a great oral placement cue for him. This is helping him
La, la.
dissociate movement so that his jaw doesn't follow the tongue. He's also doing some neuromuscular re-education because he had a tongue tie repair
Like
recently.
left, left, left. Up, shung up. Left. Yeah. Good. Left. Yeah. Left. Yeah. Good job, bud.
Hard stuff. We will have also have done the bite blocks where we pull for stability, and then we're also using them as a placement dissociation cue.
Smile. Right. Smile. Tell me. Da. 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 Da.
I could be pulling on that bite block at the same time as he's doing that speech sound. It could be like double whammy right there. Just kind of get it done, which is great. Okay. We have one more video and we're done, guys. Super exciting. Okay. So we don't have a video for this. I apologize again, but this is our low jaw, right? We have 5 sounds there, and that's 2 vowels as well as K, G, and H. So this is that wider open, right? So what do we need as part of our oral placement program to get everything where it needs to be? We need the tongue to get back, right? So we're stimulating that tongue, maybe with some type of Toothet or Z-Vibe or Sensi. Then we're doing a bilateral slow feed because that gets everything retracted. We're doing a spoon slurp to get that tongue back. We're also doing bilateral chewy tubes to get that grating and movement for that. And then we're also using a bite block number 6 to make sure that they have stability. We're pulling up to 15 seconds to get that. So the last thing I want to tell you about is another program that Diane Barr has developed. It is a vowel program. She basically helps us learn how to teach clients how to say vowels, because when we really think about speech, it's much easier to understand speech when our vowels are intact. You can say, how are you? And you can understand that, how are you? You can understand that when you have intact vowels. You don't even need consonants. My daughter the other day said something like potato. And yeah, that could be tomato or potato, but I knew what it was because the vowels were intact. The consonants were not. So she teaches us to use bite blocks. That's BB, number 2. That's bite blocks. The same bite blocks you're using for jaw grating. We're using them also to put in the mouth to get sound. So, example, E. Okay, and she's going to show us the rest of these, so we don't have to get crazy and show them here. This is our mid vowel, this is our back vowels. She also uses things that are called jaw closure tubes, which you'll see in her video, to get the back vowels. She divides all of these sounds up so you can kind of start conceptualizing them, which really helps me. All right, she loves charts and putting all this stuff together. To me, it's overwhelming a little bit until I get it, and then I can use it as a tool. So here's our last video, and I'll show you Miss Diane, who's amazing and brilliant, and such a great resource, and so wonderfully responsive to anyone who has questions. Just love her. Here she is.
So I'm going to place the bite block into the mouth here. Bite down. E. E. Okay? Now, for the next vowel, which is very difficult for many children to produce, we can use a little bit larger bite block and the jaw will be open a little more. A. A. Okay? Now, A, if you're not working on the diphthong for A, but you're just working on the more pure A, put in the bite block. A. A. Okay. Another vowel that's difficult often to facilitate is eh, or the short E. Eh. And then widest jaw position with the front vowels is ah. Ow. So you get the idea of how we're facilitating the jaw grading in order to get the child to produce the vowels. Now, for the back vowels, which have the lip rounding, we can use tubes or a round item that gets larger and larger. So these are jaw closure tubes, and we can place these just at the lips. Ooh. Oh. Oh. Ah. Ah. So this gives you the idea of how we can use tools for oral placement in therapy to facilitate the motor plans we discussed earlier for speech.
That should definitely be a whole webinar in itself. So just to tie everything up in a bow here, today in review, what we talked about was typical and atypical jaw movement and resting posture and some of the ramifications of it. We talked about evaluating a child, what to look for, and how they're using their jaw while they're feeding, speaking, and at rest. We talked about addressing weakness and why it's so important, because the jaw is that core stability for everything else in the mouth. So we always address the jaw first or alongside when we're addressing other muscle groups like the lips, tongue, cheeks. We use sensory, feeding, speech, and oral placement tasks when we are doing therapy in all of our therapy sessions to reach our goals. The last thing I wanted to quickly throw in is that collaboration is so key. I work hand in hand with an airway-friendly dentist, Dr. Hockel. He is the one that we have made that webinar about, that airway apnea, ortho, and oral placement therapy webinar. He is amazing, and he looks at the jaw and the face for dental development and airway development, and I look at it for speech and feeding. We both look at it for resting posture. We really come together and we help our children have the best facial structure and function possible. So it's so great to co-treat with people. I also co-treat with a local myofunctional therapist who's just a wealth of information and a mentor to me. I co-treat with speech, of course, speech therapists, but sleep specialists, airway-friendly ENTs, so we can talk about why children's anatomy is looking the way it is and what we need to do about it, and then, of course, pediatricians. any other types of doctors. Also lactation consultants as well. So here's a quick and dirty tools to order form. If you're like, wow, that was 60 slides, I don't want to go back and look at all that. But here they are right here. So these are the things that we talked about today that you could order. Also, I would recommend going back to Diane Barr's website and checking out what she says and how she does it. That's a wealth of information. And I would love to take questions now if you have any.
So we're, yeah, the floor is open for questions. And just a reminder that today's webinar is being recorded, so you will get an email with that recording within 1 to 3 business days. But again, thank you, Heather, for all the work that you do for Talk Tools. It's always a pleasure. We enjoy your webinars.
Oh, thank you. No problem.
Lori says, thank you, Heather.
You're welcome. I appreciate it. Let me know. Please contact me if you need help. I love helping therapists. So if you have a child in mind, you want to send me some videos, we can kind of co-treat together if you're interested, or I can help you collaborate.
Yeah, so there's Heather's information. So if you do have a question that you think of later, you can contact her, or if you forget how to contact her, you can contact Talk Tools and we'll make sure we get your questions answered. But I don't see any questions coming in, Heather, and so I think we'll end it there.
Okay, all right, guys. Thank you so much for having me. And remember how important the jaw is for speech and feeding. And I'm sure you will be awesome. I'm hopefully, let me know. Also, I love when people contact me and let me know what worked for them and what didn't, and what areas that you'd like to learn about too, because I'm very open to that.
Perfect. Well, thank you again, Heather.
Thank you, Lisa. Talk to you soon.
Bye.
Bye.